Hi, everyone. It is my pleasure to welcome Dr. Jennifer Conway for her presentation entitled Facilitators and Barriers of Situ Heart Perfusion in Pediatric Donation. Dr. Jennifer Conway is a cardiologist at the Stollery and an associate professor at the University of Alberta Faculty of Medicine and Dentistry. An experienced care provider, Dr. Conway has previously held appointments at the Hospital for Sick Children in Toronto and the Queen Elizabeth Hospital in Charlotte, Prince Edward Island. She is currently the director of the Stollery Heart Function and Cardiomyopathy Program, a position she has held since 2018. I think we should have her online now.
Can you guys see my slides?
Yeah.
Okay, well, thank you very much for the invite today. And sorry, I'm on service, so hopefully I don't get called out during this talk. So I'm going to talk about ex situ organ perfusion and pediatric heart transplantation and some work that we've been doing here at the Stollery Children's Hospital. These are my disclosures. So today we're going to understand a little bit about why there's a need for alternative methods for donor heart preservation in pediatric heart donation, to understand some of the various methods that have been used, to examine kind of the current use of ex situ perfusion in pediatrics, and really to look at some common misconceptions and potentially barriers to the use of this technology within children and pediatric heart transplantation, and then maybe to look at some of the potential impact it could have on our current donor landscape. So this is really the main crux of the problem, which many of you are familiar with, that there are children dying on the wait list who are waiting for heart transplant. And we actually have the highest wait list mortality of all solid organ transplantations. And when we've done previous analysis of the UNOS database in the US, we know that only about a quarter of the donor hearts are used. And now there's various reasons for that. Some of it is donor quality, for instance, but also distance to the donor site is also one of the stated reasons why donor hearts are turned down. Currently, our method of heart preservation is static cold storage, so really putting the heart on some ice. But there are newer base perfusion strategies which are being used more in adults, and we'll talk a little bit about that. And these are really based on temperature of the perfusate. So they can be hypothermic, for instance, or normothermic. And then there's another category called subnormothermic that we'll talk a little bit about. The traditional heart preservation of using cold static storage, is really simple. It's reliable, reproducible, and cheap. So really any site can do it without a lot of manpower. It does slow cellular metabolism, but there is a limited time that the heart can be outside of the body because the myocardium still remains metabolically active. And then that metabolic activity leads to ischemic injury and then damage to the myocardial and endothelium. And really, you're not able to assess the quality of the allograft using this form of preservation. When we talk about perfusion strategies, as I said, they're really based on temperature of the perfusate. Hypothermic perfusion does supply oxygen and nutrients to the donor and removes metabolic waste. It does allow for a longer out-of-body time, but you can't really assess function. There is issues with myocardial edema, and it has been stated to be expensive. Normothermic perfusion, which is really at body temperature, supplies oxygen and nutrients to the donor, removes metabolic waste as well, longer out-of-body time. And in some designs, you can assess the contractile function of the heart. There can be technical and mechanical errors, and in this site of setup, those type of errors can lead to warm ischemia because the heart is at higher temperatures and remains metabolically active. It does require additional personnel, transportation-specific requirements, and again, is a lot more expensive than cold static storage. Normothermic perfusion has been used in donation after brain death and also donation after circulatory death for heart transplantation. And the adult experience is summarized nicely in this meta-analysis, which really looked at 260 hearts that were supported on a specific system called the Organ Care System, which is the main commercially available one. 173 of those were donation after brain death and 87 donation after cardiac death. This included 12 studies with 741 patients. And what they found really is that there is no difference in the 30-day outcome when you compare, for instance, donation after brain death with cold static storage or donation after cardiac death. There were no differences in length of stay or primary graft dysfunction, rejection, or allograft vasculopathy. And so the conclusion from this meta-analysis is that it's a safe and effective technique. It can enlarge the donor pool by using both brain death donors and donation after cardiac death. And it does allow for a longer body at a time. So it allows you to be able to get donors potentially from further away. The pediatric experience is limited, but there is a group from Germany. It's a single center report, and they used the OCS system in those with surgical complexity, so mostly congenital heart disease patients, and where they predicted that the transport time would be much longer than they would like. And these were all brain death donors. There was no recipients under the 15 kilos because this particular device needs a donor weight of a minimum of 45 kilos. About half, as I said, were congenital heart disease. And so what they found really was that there's no difference in the intensive care stay, in the hospital days, or in medium-term survival with these patients. So although there were higher risk transplants, the outcomes were similar to those compared to kind of cold static storage. And then the other recently published paper is from the group in Newcastle, Great Ormond Street, who used ex situ perfusion in the setting of donation after circulatory death. And they transplanted 6 children with these donors, and they were able to show no difference in ICU or hospital stay and 100% 1-year survival. So really encouraging initial clinical studies. So what is the issue in pediatrics? It fundamentally comes down to the fact that most of all the devices that are either currently available or in production are not really designed to support smaller hearts. And that, as you can see from the studies, the minimum weight of the donor was about 45 kilos. And so with that, my colleague, Dr. Darren Freed, has come up with a perfusion device for smaller hearts, and really it can go down to potentially 5 kilos. And it really fills a gap in the market where there's been no device designed for smaller donors. This design is continuous perfusion at subnormal thermic, so room temperature, and that allows some safety margin because there is lower metabolic demands with the temperature being a little bit lower, and also allows less energy to be required, so the device can be small or lightweight and portable. And we have done a number of studies using a porcine model where we have supported these piglets on the device. And we've also done some transplant experiments, which have been very encouraging so far. I'm just going to skip that. This is just some of the metabolic kind of activity of those hearts that have shown kind of stable pH, oxygen consumption, and lactates kind of over the course of being supported for 10 hours on the device. So really encouraging initial studies on this pediatric-specific device. Oops, and we've also, just go back. This is just a video, if it will play, of a heart that was on the device for about 10 hours and then retransplanted. And this echo just shows that the function is good after that amount of support. So we may start to develop the technology, but with all technologies, and especially in pediatrics, it's sometimes hard for us to change our management. And so one of the things that we thought was important was to try to understand if we are ready for this kind of paradigm shift in donor management, because we've been doing the same thing for years. And so we undertook a qualitative study, which interviewed a number of healthcare professionals from across North America to kind of understand their knowledge about ex situ perfusion. So in general, very few people have used it or knew that it had been used in adolescents. There was limited knowledge about which sites had clinical or research programs. There was a large range of the understanding of the technology, and that came from literature, presentation, word of mouth, but few had used it in practice. In terms of specific considerations, there was worry about would it fit all donor sizes and what kind of would that range be, how we would present this kind of new technology to families, and how we would support kind of shared decision making and what our consent process would potentially look like. People thought that this type of technology would be a good way to assess, sustain, and rehabilitate donor hearts, and that it could potentially increase the donor heart pool. It may decrease wait list time, and therefore patients may not require ECMO or other mechanical supports as our wait times could potentially be shorter. And then lastly, there was some worries about potential issues with edema of the heart, or what would happen if the device malfunctioned. There were some ethical considerations that had kind of come up with respect to DCD. And then obviously there was some concerns about really the unknown of this technology in pediatrics. We then went on to kind of take the concepts that came out of this qualitative study, and we've just completed a survey of 68 heart transplant practitioners from around the world. It was a 28-question survey, and really the themes that we saw in the qualitative study kind of came out in this similar study. So the potential positives were seen as decreasing waitlist mortality, increasing safe travel distance, being able to potentially serially assess the heart and rehab the donor heart, and then negatives include could there be possible damage to the organ during the time that it was mounted, what happens if the device malfunctioned, what would be the costs, and really that lack of pediatric-specific data. And I think this information is very helpful for us to know, because as we develop this technology further, then these are the type of things that we'll consider as we're trying to educate people about the use of this technology. And then lastly, we've also just completed surveying families about it, and there is variable knowledge about the use of Situ Heart Perfusion, but most families believed it was an excellent innovation, that it was important for them to understand complications, for instance, during the consent process. They thought that utilizing Situ Heart Perfusion was very similar to utilizing something like ECMO or other medical technologies, and they thought that it was important to discuss this early in the transplant process when this type of technology is widely available. So lastly, do we think we could see a potential impact with this new form of management strategy for donors? And this was a study that we did using the UNOS registry, where we took all donors who were basically turned down due to distance. And then we figured out that if we could extend the donor, the total kind of out-of-body time to 5 hours, which was the median time within one of the adult studies, or if we could extend it out to 10 hours, kind of how many donors would we be able to accept that were turned down. And so if we permitted the time to be about 5 hours, we would have been able to take 80% of the donors that were turned down for distance. And if we were to extend that time to 10 hours, and that would be 100% of the donors would have been able to be accepted if that was the sole reason that they were turned down was due to distance. So in conclusion, innovations in perfusion technology have the potential to impact donor usage. Adoption of the current technology has been slow in pediatrics. Our current devices do not really meet the needs of pediatrics due to size limitations, and then ongoing knowledge development and education is needed to decrease barriers and really move our field forward to the use of this in pediatric heart transplantation. And last slide, sorry. I would just like to thank our funders of all the work that I presented today. Thank you.
We'd like to prioritize questions from online people. I'm not sure if we have any.
Do we know if there's any virtual questions? Okay. Questions from the floor? Dr. West. Oh, I don't think your mic is on. 1 second.
Hello.
Yeah.
Very nice presentation, Jennifer. And I'd just like to point out that this is the kind of novel work that can be done in pediatrics, and the CDTRP has been very proud to support this work. I think it's going to have a big international impact for this underserved population. Thanks, Jennifer.
Thanks, Laura. Yeah, and thanks obviously to CDTRP for all the support they've given us.
Another question? I had a question for Dr. Conway. So when you nicely showed the potential impact of these organ preservation strategies using UNOS data, which I think is very important. But as you very well know, we're a bit more cavalier about distance traveled in Canada. Do you have a sense, it may not have the data, but a sort of a hypothesis about what the potential clinical impact of sort of ex situ perfused organs would be within the Canadian context for organ donation?
Yeah, I think there's probably a lot of things that we may not understand about prolonged ischemic time. So you know that at least in the US and most of the studies that have been done, that when you reach beyond that 4 hour of ischemic time, that it has an impact on kind of overall outcomes and survival. Now, we at our own center, and I would probably say in Toronto as well, don't necessarily see that. And it may be because of the perfusion-based strategies that we use, for instance, or the perfusate that we use. But I do think that we do see a number of hearts that struggle for quite a number of days afterwards. Some patients end up on ECMO, that they need time to kind of rehabilitate that heart. And those all are potential risks for kind of other complications. In addition, I don't think we truly understand what the impact of ischemic damage is on the endothelium and how much role that may play long-term in allograft vasculopathy or really increasing the risk of rejection. And so actually that is another study that Dr. Fried and I will be starting in, because we've just recently got some funding to kind of have a better understanding of that kind of impact on the endothelium with kind of cold static storage versus kind of ex situ perfusate of a heart.
That's fantastic. Do we have, just checking in again, do we have any questions from the online attendees? Okay, Dr. Weiss.
Hi, Jen. Obviously, great work. And I guess I'll ask a question that I've asked in other venues, in the sense that considering most children who die in the PICU don't die through a brain death pathway, but instead die after withdrawal therapy, using this technology for a DCD donor base in pediatrics, is this something that is going to be explored in maybe the next round of surveys to see what the appetite for that would be among pediatric cardiologists?
So as I presented, there is already at least one site that's using it for DCD in Great Ormond Street. Our device may not be the best suited for DCD because it is subnormal thermic. And I think they have found that you get more edema with lower temperatures when you support DCD hearts. There is potential, obviously, to change that. There is a group, it's the kids who has specifically designed a device for DCD. I think Osami Hanjo is a lead for that, and they'll be kind of testing that out in the near future. We haven't talked about specifically diving into DCD. I think there's obviously a lot more than just how you support the heart that goes into people kind of taking that kind of strategy. And so, no, we haven't specifically talked about that. I think as we get further down the road, that may be something to explore, but not something that we've specifically talked about doing currently.
Thanks.
And then I had another question that was sort of related to my initial question with respect to distance and changes. And you sort of alluded to it, the potential risks of a long ischemic time on short and long-term post-transplant outcomes. So at the beginning of your talk, you nicely showed studies that had compared ex situ perfusion studies versus standard cold ischemic exposures. And you had shown that there was no real difference, which is favorable, but you did allude to the ex situ perfusion studies being a higher risk cohort. So in those studies, do you know, had they compared higher risk patients that had both cold exposure and a long ischemic time versus those that received ex situ perfusion? And were there benefits associated with ex situ perfusion?
So in the pediatric study, no, it was just whoever. It was like their first, they compared whoever came for transplant kind of at around the similar time. It was more congenital heart disease in those that had the ex situ perfusion. So they were higher risk. They didn't really, because it's done at a pediatric center and we only do so many transplants a year, they weren't able to do that. And in the meta-analysis, I don't remember seeing that, Michael, when I reviewed it. I could be wrong. It may be in there, but I didn't really necessarily tease out that bit of information from it.
Yeah, I mean, I think it would be safe to assume that it's a higher risk cohort that receives ex situ perfusion because it's like a deviation from the standard of care. So yeah. Regardless, it's extremely fascinating. Unless there's other questions, perhaps we'll proceed with our next speaker. Any question? Last check for questions from the virtual world. All right. Okay, wonderful. Thank you, Dr. Conway, for an excellent presentation. Back to the ward for you.